Hello, and welcome to our talk today on supplementing clinical exposure with simulation. How do we get there? I'm Tonya Schneidereith, Associate Professor at the University of Maryland School of Nursing in Baltimore, Maryland, in the United States.
And I'm Kim Layton. I'm Executive Director of the ITCON Clinical Simulation and Innovation Center at Hamad Medical Corporation in Doha, Qatar.
For our disclosures, I, Tonya Schneidereith, am Chief Executive Officer of Simple Simulation LLC, a simulation consulting company in Baltimore, Maryland, in the United States. Dr. Kim Layton has no disclosures. So we have about 20 minutes to provide tips on how to supplement clinical exposure with simulation. In that time, we hope to address these three learning outcomes. 1, describe 3 benefits to supplementing clinical exposure with simulation. 2, summarize findings from systematic reviews of clinical learning outcomes. And 3, identify at least 4 key criteria of the healthcare simulation standards of best practice simulation design.
Now imagine being the clinical instructor for brand new students who were responsible for providing care to patients on an orthopedic trauma unit. The patients included one who was hit by a train with multiple fractures, an elderly woman who laid on the floor for 5 days after falling and breaking her hip, developing rhabdomyolysis and requiring dialysis. Another young man fractured both of his heels after jumping from the 3rd floor in a suicide attempt. These random learning opportunities were not at all appropriate for my beginning brand new nursing students. However, experiences like these can be supplemented with simulation in a controlled environment where educators can create and facilitate learning experiences more appropriate to the level of their learners. Now, the research clearly shows that with well-designed simulation experiences, we can improve higher order thinking skills such as critical thinking, clinical judgment, and clinical reasoning. We can also create simulations that support learners to enhance their non-technical skills, such as communication, prioritization, delegation, and teamwork. Now, think of a high-risk, low-volume patient, such as one with pulmonary edema. Now, time is of the essence with this diagnosis, but learners may never see that type of patient during their clinical time. So we create these patients in the lab and allow all of the learners to assess and treat them. Even high volume patients, like those with heart failure, should be in the sim lab because many learners won't see this type of patient while they're in school. Additionally, we can repeat scenarios as often as we need, allowing learners to make mistakes and learn from them, something that we cannot do in real life. Now, there's been extensive research to identify how well a variety of learning needs are met with simulation. The simulation has always been held to a higher standard, especially because the cost has been high. So we were curious as to what learning outcomes were associated with traditional clinical education. We conducted a systematic review of the quantitative research literature, and we found no evidence that the way that we've always conducted clinical education for decades actually improves learning. This resulted in what's known as an empty review. So we thought, well, maybe the answers are in the qualitative literature, but we only found 6 studies, and the results didn't allow us to form any kind of meaningful conclusions. Now, our colleagues Sharpneck and Kavanaugh's ongoing research shows that newly graduated nurses are not ready to take on their roles after graduation, and their readiness decreases every single year. So in 2015, only 23% of new nursing graduates were competent to begin their practice. In 2020, it was down to 9%. This is very concerning. But we believe that we can make a difference through targeted use of simulation.
And so the topic of our talk, supplementing clinical exposure with simulation, how do we get there? As we begin to think about that, getting there should include implementation of evidence-based standards. Multiple organizations have created evidence-based standards that can be used to guide implementation of simulation. The Society for Simulation in Healthcare has accreditation standards which provide benchmarks for simulation experiences and programs. Other organizations, such as ASPE, with an I, ASPE, and ENACSL, have standards of best practice to guide the design of our learning experiences, how we implement them, how we evaluate them, and how we manage operationally. These organizations include the Association for Simulation Practices in Healthcare, the Association for Standardized Patient Educators, and the International Nursing Association for Clinical Simulation and Learning. Dr. Wilson Keats will be speaking next about the newly released standards from ENACSL, the Healthcare Simulation Standards of Best Practice, which apply to all healthcare professions. This is the 4th edition of the standards, which were first published in 2011. They were developed by multidisciplinary teams and have been endorsed by over 20 organizations worldwide. Today, we will focus on a portion of the 11 criteria that comprise the simulation design standard. We're focusing on the simulation design standard because 1, it provides a framework and roadmap for developing effective learning experiences. As we break down the standard, you will see how it allows focus on specific aspects of the experience. It integrates best practices from adult education, clinical standards of care, and simulation pedagogy, to name a few. It allows the alignment between the simulation experience and the program goals and institutional mission. If considering SSH accreditation, demonstrating this alignment is part of the program management criteria. And lastly, it provides a systematic process that is purposeful and flexible. There are 11 separate criteria within the standard, and so for the purposes of this presentation, we will expand upon a few of these.
To demonstrate the simulation design standard, we're going to apply a select few of these criteria alongside of the simulated case to help you conceptualize the application of this standard. So let's look at poor Mr. Jones. He is a 35-year-old male, and he was on his way to work this morning, but he was injured in a motor vehicle accident. Upon arrival to the emergency department, he was diagnosed with a liver laceration and resulted in significant blood loss that required transfusion. But what happened next is the foundation for the creation of the simulation experience. The patient had a blood transfusion reaction. We set out to learn more about this incident so that we could create our scenario based on identified learning needs. We interview key personnel. Let's see what they have to say.
Oh my gosh, it was so busy that night. I remember we had several trauma patients and it was very difficult to keep up all the orders. Each time I got a call, I put that patient's blood bags on the counter so the nurse can pick up them even if I am busy with other rooms.
Oh, we were really busy at that night because there was huge accident on roadside and we got a lot of patients. So, and then we were short of some nurses as well because some nurses went for the COVID side to support the COVID patient. So I got all in sudden like a call for the blood. So I ran to the blood bank. So usually we give for the trauma people O negative. So I saw there some bags. It's written as O negative. I just grab it and come back to the ward and I just give that blood to the patient. So the take person was not available in the blood bank because he was busy with another room. He was preparing some blood for the other patients.
I noticed also that there is no evidence that the blood was checked and the form was signed from the blood bank tech and the nurses to check if the blood, it was for the right patient and it was the right blood group for him also. Another thing, what I noticed also, that there is no cross match before administering the blood to the patient, and that's why the patient received incompatible blood and had a reaction.
As you can see, policies and procedures weren't followed. So this will be the focus of our simulation design. Now that we knew the issues as a result of our needs assessment, as simulationists, we need to meet with content experts to ensure our simulation is realistic and accurate. Some of us have been away from clinical practice environment for quite a while, so we need to make sure that we understand the current policies and procedures related to blood transfusions. I'd also like to just point out that there's a new standard for professional development of simulationists as well that you'll want to take some time to read.
So in coordination with content experts, a backstory, script, clinical progression, and cues should be developed to help place the learner in a realistic clinical situation. Using a video like this one can help add to the psychological fidelity. When we consider a patient recently involved in a motor vehicle crash, pay attention to the car on the right side of the video. Notice the deploy of the airbag, and then use that image to feed into the description of what the learners will encounter in the simulation. So for the objectives, they must be written for the learner, and they should be specific, measurable, achievable, realistic, and timely. An example of the objectives for the motor vehicle crash could include to identify 3 steps of closed loop communication, describe 2 barriers to effective team communication and collaboration, and to articulate systems currently in place to avoid medical errors. The modality is related to the simulation-based experience that must be aligned with the particular way that you want to introduce this. So for example, for communication, one would utilize a standardized participant because they would be able to communicate readily based on the verbal and nonverbal cues provided by the learner. If you are practicing a particular task, for example, placing a catheter in place, then using a task trainer might be the modality of choice. For fidelity, we ask that you use various types of fidelity to create required perception of realism. In our simulated case, the simulator was moulaged to show bruising from the seatbelt, and then bags of the packed red blood cells were created to allow for realistic application of safety measures. The simulation should be at a level appropriate for the learner. They should have prior exposure to the content and the ability to achieve the expected outcomes. For example, novice nursing students would not be expected to act appropriately in a resuscitation scenario. However, a resuscitation scenario would be appropriate for graduating nursing students.
It's important that the learners understand what's expected of them when they come for simulation. Consider again the level of the learner. What is it that they need to know in order to be successful? And have you presented this material in their class? Have they experienced the patient simulation in the traditional clinical environment? Think about how the learners might prepare ahead for your simulated patient. Now, if you use my new students as an example, I would want them to read about communication strategies, especially with other team members. I'd also want them to review blood types and interactions, as well as the local policy and procedure for transfusions. Pre-briefings and intentional discussion with the learners, and it occurs before the experience starts. It's intended to balance the cognitive load demands and to set the ground rules so that all the learners have a common mental model. We also want to decrease learner anxiety and increase psychological safety. One way to do that is by adopting the basic assumption. It states, we believe that everyone participating in activities at our simulation center or lab is intelligent, capable, cares about doing their best, and wants to improve. There are many required elements for briefing, which includes setting expectations such as the length of the scenario, debriefing, break times, the agenda, ground rules, fiction contract, confidentiality, methods of evaluation, a review of the objectives, as well as orientation to the sim environment, the equipment, and how it's going to be used. That's a lot to remember. We use the template so that we don't forget anything. Now, debriefing is a vital component of the simulation experience where we guide learners in a reflection of their actions or lack of actions when caring for the simulated patient. We help them to explore their decisions and actions by using certain types of questions to help them reflect. For example, I noticed that you didn't check the patient's armband before hanging the blood. Can you tell me what you were thinking at that time? Asking questions using this advocacy inquiry approach helps us also to manage our biases. We might think they just forgot, while there may be other reasons that we should be exploring. Using open-ended questions like "tell me more" are also helpful. There's several debriefing models, and you'll learn more about debriefing in other sessions today. There are several methods of evaluating the performance of the learners: formative, summative, and high stakes. Now, formative evaluation occurs in simulations used just for learning purposes. Remember, we learn more from the mistakes we make than we do everything right. However, it is important to have feedback and guidance from trained facilitators to address those errors. Summative assessment occurs at the end of a period of time, perhaps at the end of the semester. Now, high stakes assessment is similar to summative, however, there's consequences. So for example, if the performance is poor, there may be a grade assigned to that performance, and perhaps the learner is not able to advance in their course or to obtain licensure. Those are high-stake outcomes. So what do we evaluate? Well, that depends on your learning objectives. So for this patient, we would evaluate their understanding of closed-loop communication, the steps and barriers, as well as systems analysis. These are all cognitive evaluations, which we can assess through observation, as well as the debriefing discussion. If we wish to evaluate performance, then we can use rubrics and checklists to evaluate that. However, we need to ensure two things. One is the evaluation tools need to be evaluated with the group that you're evaluating. For example, using an evaluation tool that's validated with practicing physicians with a group of nursing students would require validity work. And two, the evaluators must use the tool the same way. This is really hard to create. But it's vital if your results especially are going to be used for high stakes outcomes. Now, two places to find evaluation instruments are in the iNaxle repository of instruments and the Evaluating Healthcare Simulation website, where you can download tools immediately and at no cost. And that link is on your screen.
And next is pilot testing. So before implementing with learners, the simulation should be pilot tested in the real space with participants similar to the expected learners. During this time, you can identify any confusing or misleading cues or other elements that may result in an inability to meet expected outcomes. Then you would make changes and improvements based on the pilot. It may not always be possible to pilot test if doing just-in-time training or if limitations of space and/or resources make pilot testing impossible. What you can see here on this image is this space that we use for our pediatric simulation. So the image on the left shows the simulator that we use as we orient our students and learners to the monitor, to the electronic health record. And then the image on the right shows the medication cart and also the medication dispense machine. So as we are pilot testing in the real space, we also make sure that all of this equipment functions in the way that we expect. And so in summary, our systematic reviews of clinical learning outcomes demonstrated empty reviews. Supplementing clinical exposure with simulation offers multiple benefits, including opportunities for repetition, higher order thinking, and cases that are specific to our learners' needs. The Healthcare Simulation Standards of Best Practice Simulation Design offers a framework for developing specific learning experiences. Here's a list of the references that we used for our talk today. And we thank you for your time. And now we have an opportunity for questions.